Okay, we'd like to reconvene and get going with the last moderated discussion section of the day today, where you'll have an opportunity to ask questions of our panel. And we're very fortunate to lead our moderation section is Ellen Gritz. She's professor and chair of the Department of Behavioral Science and the Ola Stribling Distinguished Chair for Cancer Research at the University of Texas MD Anderson Center. She's an established leader in cancer prevention and control research and an internationally known investigator. And she sits on numerous advisory boards and earned her PhD in psychology from the University of California at San Diego. Okay, Ellen. Take it away.
Thanks a lot, Steve, for that lovely introduction. So I just passed by those dancers again, and just imagine us all in our sequin gowns and the gentlemen in tuxedos. We're going to have a rousing 30 minutes here. We had 5 wonderful papers, very challenging. We heard all about the importance of causal modeling, statistical designs, things I've never dreamt of, all kinds of simulations, very sophisticated, and then the issues about measurement and appropriate designs and RCT versus others as well. So I know that there's going to be lots of discussion, pushback, encouragement, and facilitation from the audience. You have five papers to draw upon. So who is my first person?
Hi, my name is Ana Ortiz. I'm from the University of Puerto Rico Cancer Center, and I'm representing table number 7. And basically some of the issues we're going to bring are maybe already addressed in the papers, but since we're not sure, we just think it's important to highlight their importance for their inclusion in the supplement. And they are the following. Basically, we think that race, ethnicity, and culture should be taken into consideration in the design and evaluation of multi-level interventions, as these are going to interact at all levels. We also think that it's very important that multi-level interventions and multi-level research be recognized as an important tool for reducing health disparities. Basically, we discussed the example of breast cancer, where certain minority populations, such as African Americans and Puerto Ricans, have very high screening rates at the individual level. But then when you look at the other side of another outcome, you see very high mortality rates also in these populations. So for example, at the biologic level, there may be some differences, but at the same time, there are going to be other system levels that are going to be affecting these outcomes. And we think these are important issues to be addressed in the supplement that we just wanted to mention.
So that's another very important point that came up in these papers, that we can go below the skin, so to speak, to the biological level, down to the molecular and the genetic levels, and those may need to be modeled in as interactions as well.
I'm Shin-Ping Tu from the University of Washington, Department of Medicine, and I am representing Table 17. And our group had a very detailed discussion about data, and how the availability of good quality data seems to be so key to be able to do good multi-level interventions. However, the collection of this would clearly be very, very expensive, and for a lot of us on an R01 or different mechanisms, that would be quite challenging. So the question that we would love the presenters to consider is to perhaps also factor in whether there may be some other mechanisms or agencies that would be able to do these excellent quality data collections, and then for those of us who are doing the research could then have access to these. And on the related level, our table was very intrigued with the computer simulation as well. However, for those of us who are not engineers or have prior experience with computer simulations, we found that it would be very interesting to get some more concrete examples, and then potentially even a potential how-to-do list so that we can actually get started to be able to use this important tool.
So now we've had 2 sets of questions. The panelists have comments.
So around the data question, Table 20 actually had some discussion of that also, and I guess there are 2 kinds of things. One is an example, well, both are examples. One's an NCI example, but I left my notes on Table 20. What was the thing called with the wiki? about the data? GEM. So one of the issues is, do people, see, I remembered some of it. Do people even know of the availability of some data and measures that they could use? And this seemed to be a vehicle for, I'll use the word disseminating, discussing information, about data and data availability. So that's one example. And maybe we're lucky in the VA. I see Becky standing up in the back. Becky's done a primary care survey in the VA, and other people use the data from that. And it's a way of characterizing, our medical centers and primary care clinics. Similarly, we have since 2004 administered an all-employee survey. And so each year we get like 175,000 respondents and measure organizational factors, organizational work group, and medical center concepts. Now, the good news about that is it's a common measure. Similarly for Becky's, it's a common measure across all 140 sites. The bad news about it is you may not agree with the conceptual model that we use to decide what to measure. And because you're always limited in the number of things you can measure, where you come from with your conceptual model may not fit the data that we've collected over these years. But at least those are a couple examples of data being available about some of the concepts that we're talking about in terms of these multi-level measures.
Just a couple of quick comments. I apologize, someone also mentioned the emergence of EMRs, and I think that's going to be a sea change. I also recommend to people, Gary King had an article, I don't know if it was the last issue, but a recent issue of Science, talking about the wealth of information that is now becoming available. And it's not traditional information. It's not the surveys. It's not EMRs. But like one example would be that Google detected the influenza outbreak about a month before our surveillance systems did. So if we think creatively about a lot of these issues, there are many, many more opportunities than have ever existed before. And there are challenges that Gary identifies, but it's worth thinking outside the conventional data, the SEER, CMS kind of data, which is incredibly valuable, but the amount of information out there is almost limitless.
Any other panelist comments? Okay, table 2.
Hi, I'm Sean Anderson from Kansas City, and representing table 2. And we had 2 issues. One that overlaps with the previous comment. Thank you. One that overlaps with the previous comment about the need for concrete examples. We thought that all the papers were excellent and of interest, but felt that they would all be strengthened through some concrete examples given to the different types of issues. So I just wanted to reiterate what was just expressed before. The second piece that we talked about and spent a fair amount of time on was the issue of efficiency and the issue of looking at what are the different measures, what are the things that we should be employing, and what are the recommendations from the authors of the papers in terms of their multiple expertise on what's doable, what's actually something that can be done in the scope of the work that we're doing in terms of measurement, and what are their recommendations. So we thought all of the papers would be really strengthened and helped by having some real concrete examples about, given where the field is now and your understandings of the field, where we should be going and what's plausible to do, and what is your feedback on that?
Feedback? No one wants to comment? Okay, Betty.
Hi, I'm Betty Thompson from the Prework Cancer Research Center, and I represent Table 16. And we were all very intrigued by the notion of time as a third dimension. And especially when we saw the flow chart that looked at family support being critical at some point, physicians being critical at other points, and so forth. What we want to know, however, is how in the world do you capture those kinds of differences from logical kind of point of view, specifically developmentally, what do we do? How do we know when to talk to organizations, when to talk to individuals, when to talk to the physicians and the providers and so forth? So any light you can shed on that would be much appreciated.
Go ahead, Jeff. My answer is probably not going to be entirely to your liking. I think one of the points in my paper is that we should start treating time as an analytic variable as opposed to something we measure T1 to T2 and end of story. And I think there's a lot of information, a lot of work that's already out there that would help inform the sort of questions you're asking. So for example, in social epidemiology, there's a lot of work that's been done that tracks growth trajectories in certain clinical outcomes and certain behaviors among patients that would help inform, for example, when an intervention might be applied, to whom it might be applied, and how that information and how that intervention might be likely to kind of change in terms of its impact over time. So again, not a direct answer to your question, but I think that there is a body of work out there that would get us closer to answering that question.
I'd like to just piggyback, and it's a little bit of an answer to the prior question as well as this one, but one interpretation of time is history, which I think we also have to think about. And all too often, I think when we do studies that look at organizations or even people, we forget about the fact that there's a history that got them up to the point where we finally got involved to study them. So I'll use the organization since that's where my work is. And a very quick story is we're studying 8 children's hospitals in the state of Ohio as they're trying to implement some evidence-based practices around patient safety. And we discovered in 2 of these hospitals where the practice that they're trying to implement is the use of alcohol-based skin preps, that these 2 hospitals weren't getting anywhere. And they're both in the same city, and the surgeons practice in both hospitals. Well, we would never know to measure the fact that a number of years ago, they had a fire in the operating room used because of the alcohol-based skin preps that the prep pooled and ignited. So nobody there wants to go near the stuff. And if you were to use measures of organizational culture or leadership or any other variable I could name, you're not going to find that. We didn't find that until we talked to the people about what's going on here. And so my conclusion from that is, while there are some things that we do know about the effect of context in organizational change, that there's a lot of things we don't know. And there's a lot of special causes sometimes that really mess up our work. But the way to understand and to help build our models, because I think we're at a stage that we're still building conceptual models as well as testing the pieces, is to do some qualitative work. And we found what we found through interviews. And we also found the strength of the feeling around that particular issue. So, summary: importance of history, importance of doing qualitative work to be able to identify, some very important things that affect, the intervention.
Yeah.
So 2 time issues that come up that Jeff mentioned that I think would relate well to Joe's paper on simulation are sequencing and duration. So it could very well be that multi-level interventions are more effective if sequenced in a particular order, such that some of them come in earlier than others. And we strongly suspect that interventions take time to have an effect, and then their effect decays over time. And that those can vary significantly from one intervention to the next, or even across different levels. This is something that we probably need to attend to more in our research, rather than just measuring effect sizes, looking at duration of buildup or decay of effects. But it is possible, I think, with simulation models to play with time. You can expand time, dilate time, accelerate time, and so forth. So it is possible at least to test out what your various assumptions are. If you sequenced interventions in a particular way, do they have to start one after the other? Could you stack them? Could they be staggered? How much should the staggering be? And if you make certain assumptions about how long it takes for the effect to build and how long it's going to decay, how do those affect the various outcomes that you can get? And I think simulation offers you a nice vehicle for testing out, essentially doing sensitivity kinds of analyses to see what those assumptions might mean in the real world. I don't know, Joe, if you wanted to add anything to that, but that does seems to be value.
No, I agree. I agree wholeheartedly. I just had a couple of other comments reflecting back on a couple of the points that were raised. In many respects, I think we're needing to build some new research infrastructure that doesn't exist now, and that's why we're struggling with this, I think. And so there are several things that need to be thought of. With regard to databases, for example, recently the Agency for Healthcare Quality and Research, who's tasked with one of the major responsibilities for comparative effectiveness research, sort of recognized early on that databases to do comparative effectiveness research didn't really exist. So they had to create stimulation to the community to sort of begin developing databases and make them available to the research community so that certain issues of comparative effectiveness could be addressed. So I think a program and trying to think about ways in which grant mechanisms and other things could be targeted to database development and collaborations would be a strategy. With regard to the concreteness, I agree. Again, I think the strategy there, though, might be more of a workshop orientation. And I think workshops could be created as another way of sort of bringing people with the technical expertise as well as the kind of clinical and policy issues together to be working on things. It would be a different format than what we're using today, which is more general and orientational. But I think that would clearly be another kind of a follow-up step to really demonstrate how to do this. And perhaps in our smaller work group sessions, we could be focusing on actually considering particular variables for particular issues. The other strategy, which is also an infrastructure one, is this is the role that research centers have served. And I think one of the best examples of that, going back a number of years, is what the Cancer Institute did with research centers to really elevate community oncology research and to move it forward. Research centers are sort of falling out of fancy. When Harold Vamis was director of NIH, he was very much, looking at the R01 not single investigator, but independent investigator model, and really not wanting to invest money in research centers. I recently heard, just the other day, Tom Ensel, who's the director of NIMH, talking about those continuing kinds of discussions, and in the current economy and so forth, NIH is really sort of looking in other directions away from research centers. But it's very hard to, in my mind, in a way of thinking, to sort of get multi-level research going when you're sort of funding R01 applications. I just don't think the mechanism aligns with the challenge, given the fact that you've got to be pulling, multiple people together and multiple databases and so forth. I don't think you can do that with R01 type research. So I think there are some of these bigger infrastructure kinds of things that if we're really going to make some progress here, I think we've got to have an effort that's commensurate with the challenge.
Good observation. We've only got about 10 minutes left, and I want to make sure that all of you get to speak, so go ahead.
I'm Roger Ludman from UMass Medical School, representing the combined forces of tables 10 and 1. We had an interesting discussion about adaptive design. I'd be interested in some comments on that. I think we saw adaptive design having perhaps a spectrum, all the way from a small RCT in which perhaps you're proposing an iterative approach to interventions. If one's not working, you back up and try the other one or a third one after that, but it's all a priori, all the way to saying that in fact adaptive design is the intervention, that is you're allowed to and expected to use a lot of resources and creativity to accomplish your end, and that the intervention itself is that. That might be more applicable in implementation study, where you get deep into the politics of an organization and are using various means and methods to try to get your intervention implemented within that setting. So I'm curious about definitions and understanding of adaptive design for its head.
Nope. Well, go ahead, Paul.
One of the things we talked about at our table in terms of adaptive design, I think one model of it is the IHI collaborative approach. And so it's very, very adaptive. Each site decides on its foci, and the rapid cycle improvement approach to change is inherently adaptive. You're supposed to just regularly, rapidly sort of change your focus. The challenge in those, and Don's a big advocate of the rapid cycle improvement, and he often says our approach, the traditional approach to research is antithetical to quality improvement. It's a little bit of a stark contrast. But the challenge is if it's not standardized or generalizable, you're never quite sure what worked or didn't work or how to generalize it. It may be good for an internal process, but in terms of external validity, it's always a challenge to know what it is that you would export under what circumstances to what places. But
Okay, side.
Hello, I'm Debbie Holden from RTI International, and I represent the Smart Table 14. We've gotten into a long discussion about the generalizability and validity of these types of interventions and how would one go about trying to build that up. And so that made us move into a discussion about if you did happen to have a study session that was looking at MLIs across each other, would we have criteria where we would know how to assess them and know which ones were high quality and should be funded and which ones were not? And as we talked about that even more, we wondered if any of the papers really talk about how we got to be here. Why is it we think MLIs are going to work? What's the science behind it? What were the assumptions that were made in order to bring us here today, so that we think it's a viable next step?
one theme that I think emerged today is we've emphasized internal validity at the expense of external validity. I think, speaker after speaker said we need to pay, or context, however you want to frame it, we need to know about external validity. I think several speakers also opined how we got here, and one was that we haven't been as successful as we would have liked with the single level interventions, and that there's a premise that maybe by combining either the additive effects or the synergistic effects will have the kind of impact that we would like to have. So if a patient intervention is contingent on changing community norms and changes in the care setting, then the individual intervention is going to have zero net sustainable impact if we don't operate at in the context and the different levels. Now that's untested, but a lot of smart people think that's a potential way to get more traction on some of the issues we want to get more traction on.
Or we realized that what we implemented did not happen because of the implication of what we thought the provider was going to do, something of that sort. Yeah. Okay, over there.
Russ Glasgow from the very engaged Table 8, probably with a few of my own editorial comments put in. Just two quick points. One about simulation modeling, just that we're very bullish on that. Probably largely, at least because only one or two of us at the table really understand it. The rest of us just know enough to be dangerous, but we're quite excited about it for the following reasons. One, we think it has the potential to increase transparency of reporting and making explicit assumptions and things that were going in there, which we think would be good for all types of research, particularly around, this is probably the incorrect term, but what I would call the impact of starting assumptions and things, or sensitivity analysis. Like in economics speak, I'm not quite sure what the modeling term for that is. Secondly, the potential for replication. which we see too often and I think is really underemphasized in all types of science, but to show through cross-validation or other types of replication. And finally, something that we didn't hear today, it might be in the paper, but that we felt was really important about it, is the potential to identify, particularly when you look for interactions, iatrogenic effects, and to, in advance, predict some things which I think we could have well known about, even simple things that are conceptualized as 1 or 2 level, like the Accord trial results or things like that, if we had really modeled those before, based on what we know. Second point, we're also big on the time bandwagon. We feel it's really been the Rodney Dangerfield, whatever, of research. It deserves much more credit. We don't know quite why. Back to, you know, Cronbach told us, what, 30, before some of the people in this room were born, about the importance of time as one of the key concepts of generalizability. But in particular, I think the notion that today it's more and more possible, and tomorrow and next year will be even more possible. Martin made the great point about history, but we have a lot of discussion about all of these different levels, really a need to do that over time, particularly thinking about organizations, because organization at day one when you start your study is not the same organization that you have 6 months or a year later, and that's true for most of the other levels there, but we usually don't do that. We just default to what we call time one was, despite the history and everything else. And the final point is just that I think particularly imperative, and probably one of the biggest challenges of time that's the most neglected, is of course sustainability and the long-term impacts, and that we could have a whole meeting, and probably will, on that. But one thing that I think is really possible that wasn't in the past today, with all the work being done trying to harmonize community-level health indicators that can be used to at least partially characterize context, that's being done now. We could maybe have another discussion about that sometime. But these geospatial databases and things that we now have to summarize some of the important social, physical, environmental characteristics.
Thank you. I'm going to let our last person at the microphone speak, and then any summary comments from the table.
Great, thanks for the opportunity. This is Jeanette Andrews from Medical University of South Carolina. And we've been talking a lot about context today, and we're hitting on timing and history, but one thing I'm not hearing is something we've been working on is readiness. And we've just completed a model of partnership readiness, which we've defined 3 dimensions. One being goodness of fit, that involves history, timing, trust, benefits, whether the benefits are mutual, and values. A second dimension, capacity, involving the competencies and skills to do the work, resources, people, finances, space, IT, other. And the third dimension is operations, communication systems, decision-making systems, and leadership. And so I think it's in the application of multi-level interventions, the readiness of the organization, the provider practice, and of course the patient. We have stages of change model, if you will, for patient readiness, and there are some readiness models for organizations, but I think we need to really look at readiness at the multiple levels for implementing them in application, and I really haven't heard that today. And I think it's bigger than timing and history.
Very interesting. Okay, final comments from the panel.
No, I just can't forget the comment that Arnie made this morning, citing Machiavelli. And as I think about readiness.
Jeff, did you want to say something?
Just to reflect some of the comments that were made in Table 20, since they didn't get full voice to their concerns. One of the things we talked about quite extensively, and I became a clear convert as the discussion proceeded, is how we engage in cumulative knowledge building in this area. These studies are likely to be very expensive, and we can't afford, I think, in an era of resource scarcity, to engage in what amounts to a series of kind of idiosyncratic, unconnected studies. It seems to me we can approach this from several vantage points. One is figuring out how to take more of an incremental approach to multi-level interventions and evaluations without trying to embrace all the moving parts simultaneously. But the second is sort of more of a top-down strategy, and that is, this may be I may be speaking about NCI here, is to figure out how we can categorize, accumulate, disseminate the information that we're learning so that the learning is accelerated, I guess, more than it has been in the past. So I see a two-pronged approach that would be great if we could kind of implement.
In addition to the infrastructure that needs to be built, I think there's a lot of pre-work that needs to be done. I think before the NCI goes off and spends several $1 million and people's careers doing multi-level interventions, some of which has been talked about already. There's a lot of work that needs to be done on measurement. There's no point in doing multi-level interventions if we can't measure with some degree of confidence the things that we think are important. We need a better understanding of causal mechanisms of the processes we're interested in studying and intervening upon. So I think the need for more multi-level and cross-level kinds of research is there. And I think there's a training aspect to it as well, that issues around simulation modeling and these other techniques, I think we just need to build up our skill set. And there's a fair amount of conceptual work that I think needs to be done. So I would say we're not ready for prime time, actually, on multi-level modeling, but I think there are some very concrete steps that could be taken to lay the groundwork so that if and when we're actually ready to make some big bets with the budgets that are available and so forth, that we're more likely to succeed. I don't think we're ready yet.